Welcome to the Depo Medrol acromioclavicular joint injection demonstration. In the following presentation, we will be following Dr. Brian Cole in a step-by-step demonstration as he administers Depo Medrol to a patient with joint trauma. The patient will receive an acromioclavicular joint injection. He has suffered from joint trauma in his shoulder from a sports injury several years ago. He has tried physical therapy, and after a consultation, it was decided that Depo Medrol would be an appropriate adjunctive therapy. Please note that this patient profile and history are fictitious and have been created for educational purposes only. When treating an AC joint with Depo Medrol, the goals are to enter the joint space with as little pain as possible and to inject Depo Medrol without injuring the joint or introducing infection. Identifying the optimal injection site requires a careful review of the AC joint within the shoulder region. To obtain the full anti-inflammatory effect of Depo Medrol, the injection must be made directly into the synovial space. To begin, the patient should be seated. The AC joint is narrow but superficial. Visually examine the joint for signs of enlargement or swelling and physically palpate it for signs of tenderness. This examination is important as corticosteroids may mask some signs of infection and new infections may appear during their use. Identify the top of the acromion. The acromioclavicular joint is located approximately 1 inch medially from the lateral edge of the acromion. Mark the injection site with a pen. Select a sterile 20 to 24 gauge needle for the injection. As you can see, within the shoulder, the acromion is the top of the shoulder blade. The acromioclavicular joint is where the acromion meets the clavicle or collarbone. The synovial fluid lies within the acromioclavicular joint space. This is the location where the needle needs to be inserted. There are 3 main ligaments of the AC joint: the acromioclavicular ligament, which connects the acromion and the clavicle, and 2 coracoclavicular ligaments, the trapezoid ligament and conoid ligament, which connect the clavicle with the coracoid. The coracoid is a projection of the scapula. Avoid introducing infection by practicing sterile technique. Wear gloves and cleanse the skin overlying the superior shoulder and distal clavicle with an antibacterial cleanser or povidone iodine solution and alcohol. Using a local anesthetic in conjunction with Depo Medrol is elective. Local anesthesia can help minimize patient discomfort, especially if the joint is relatively dry or there is only a small amount of synovial fluid present. Note, however, that Depo Medrol should not be mixed or diluted with other solutions due to potential physical incompatibilities, as described in the product labeling. Therefore, if you use an anesthetic agent, inject it before administering Depo Medrol. Always read the anesthetics package insert carefully and observe all recommended precautions. Approaching from above the joint, the needle should be perpendicular to the skin. Carefully advance the needle through the skin and subcutaneous tissues medially at a 20-degree angle through the joint capsule and into the joint. Before injecting the anesthetic, you may aspirate to be sure you are in the joint space. Normal synovial fluid, which is clear, pale yellow, and viscous, is present in the AC joint in very small amounts. If you do aspirate, keep the needle in place and remove the syringe. Replace it with a second syringe containing the desired amount of Depo Medrol. As you can see, the needle has been placed in the correct location and has entered the joint space of the acromioclavicular joint. You can see that the joint is located between the acromion and the clavicle. A few drops of synovial fluid is being withdrawn into the needle, which confirms the synovial space has been entered. If you do aspirate, keep the needle in place and remove the syringe. Replace it with a second syringe containing the desired amount of Depo Medrol. For acromioclavicular joint injections, the appropriate dose of Depo Medrol is between 4 and 10 milligrams. In general, the dose for intra-articular administration depends upon the size of the joint and varies with the severity of the condition in the individual patient. Note, though, that with increasing doses of corticosteroids, the rate of occurrence of infectious complications increases. Gently inject Depo Medrol into the joint. There should be some resistance to AC joint injection because the joint space is small and the joint capsule is dense. However, if you encounter significant resistance, the needle may be in a ligament and should be advanced or slightly withdrawn into the joint space until the injection proceeds with only limited resistance. Here, the needle has encountered the acromioclavicular ligament, which is causing resistance. Withdrawing the needle slightly allows for proper redirection and placement of the needle. With the needle in the proper area, the Depo Medrol can be injected into the joint capsule. Once the dose has been injected, withdraw the syringe and needle. Cover the injection site with a small sterile dressing. Move the shoulder gently to promote mixing of Depo Medrol and synovial fluid and to disperse the medication throughout the joint. Advise the patient of any post-injection care techniques you recommend, such as the use of ice packs or over-the-counter medicines. Also, inform the patient of the possibility of a post-injection flare. Such post-injection steroid flare may cause a worsening of symptoms during the first 24 to 48 hours following injection. As with all corticosteroids, Depo Medrol has been associated with post-injection steroid flare, tendon rupture, and crystal-induced synovitis, as well as hyperglycemia, osteoporosis, psychiatric disorders, myopathy, and growth arrest. In chronic cases, injections may be repeated at intervals ranging from 1 to 5 or more weeks, up to a recommended maximum of 3 to 4 injections per joint per year, depending upon the degree of relief obtained from the initial injection. Repeated intra-articular administration may, in some cases, result in instability of the joint.